Thank you everyone for joining us for another Learning Lunch hosted by FormatApproved.com. My name is Brian Johnson. I'm the Senior Director of Online Education with Format Approved, and I'll be your moderator today. Today's Learning Lunch title is Clinical Quality Measures, Understanding the Reporting and Submission Requirements of CQM. We're joined today by Joy Rios of Format Approved. Joy is an expert in both meaningful use and EHR proficiency with years of real-world experience in meaningful use attestation and EHR implementation and optimization. Joy has a unique talent for taking forbidding materials such as clinical quality measures and distilling them down to the information you need to succeed. Before we begin, some quick notes. Note that you can ask questions of Joy at any time during today's session by entering them into the chat area. In the second half of our session, we'll address as many questions as time allows. If we do run out of time, answers to all submitted questions will be posted to our website and sent via email link later in the week. Also, remember that all registered attendees of today's session will receive an email with links to both the slides and the recorded version of the event. So if you're looking to share this with other folks or bone up on what you've learned, we'll send that email out after the event to let you review all of it. All right, Joy, well, thank you for joining us. It's always a pleasure to have you with us for a Learning Lunch.
My pleasure to be here. As always, thank you for having me.
All right, well, let's go ahead and begin then. So quality and outcome measurement is a top priority in healthcare. There's lots of different programs that are measuring this. Give us a survey of some of these clinical quality programs.
Well, there's quite a few different programs that are both public and private that are measuring quality. And so, of course, as you're aware, there's the Meaningful Use program that is capturing quality in the form of clinical quality measures. And for this year, in 2013 and previous, it's been a total of 6 quality measures that they're looking at. Not necessarily looking for any thresholds or meeting, it's almost you're incentivized to report on them, not necessarily to perform. We've also got the physician quality reporting system. That has been in place since 2007 is when physicians started reporting. And that requires a full year of reporting on 3 individual measures or 1 measures group. And then when we go into the private programs, there's what's used mostly by health plans. It's the Healthcare Effectiveness Data and Information Set, and that is a program that's private. It's used by more than 90% of U.S. health plans, and it measures the performance on care of service. And then those measurements, which there's a total of 80 that cover 5 different domains, are the basis, or one of the bases, for the patient-centered medical home. And you can think of the patient-centered medical home which as sort of meaningful use on steroids is a term that I've heard recently. So they use the meaningful use outcomes, they also use the HEDIS outcomes, and then going even farther is the accountable care organizations. So those PCMHs are an essential component of the ACOs. So everything is sort of building on top of each other. And one thing I wanted to point out is there is another program that's similar to HEDIS, but it's actually only in place in California. It's the California P4P, Pay for Performance, and that is sponsored by the Integrated Healthcare Association. It is similar in that it's used by the health plans and health insurance companies to define which providers should be in their network and figuring out prices and whatnot. We're not going to go into too much detail about that today because it's not really a nationwide program, but it is something to be aware of because it is gaining traction. It is something that, it is an outcome measurement tool that could potentially in, a few years' time be expanded to nationwide.
And just in case people may not be completely familiar with the term, an accountable care organization, this is something that was set up by the Affordable Care Act, and these organizations are really a pay-for-performance vehicle or scheme. I'm not sure how to describe it exactly, but That's the whole purpose of an ACO, is to move toward a pay-for-performance model. Correct?
Correct.
So you've got all this alphabet soup of different programs and measures. What is, why is there so much attention being paid to quality measurement now?
Well, we're not in a pay-for-performance model just yet, but we're sort of in a pay-for-reporting area. And one thing I'd like to point out is if you look at the goals, and you kind of take a step back and look at the big picture, the core principles of the meaningful use, the first words of it are improve quality. We're trying to improve quality, safety, efficiency, and reduce health disparities is the first line item. And those first two words are, improve outcomes and improve quality. So in order to do that, we have to be able to measure how we're doing, find a baseline, and then find ways to improve upon it. So I'm sure you've heard that axiom, like, what gets measured gets managed. So if you can't measure it, then how can you do better? So that's part of that. And the core principles of the patient-centered medical home, the PCMH, they've got a long list of core principles, but down the line is physician accountability. And typically what that means, I've heard, accountability means you're posting your numbers out on the wall, for you to see on a regular basis, for the, nurses and staff and potentially even patients to see. And that can be somewhat scary because the numbers aren't always pretty. And physicians, often assume that they're doing a fantastic job. And they probably are, and usually are, taking great care of their patients, with the patients that they see face-to-face in the office, in the exam room. But oftentimes they're not realizing that they're not taking as good of care of patients who are on the fringes, patients who maybe don't come in for their office visits very often, or the ones that don't have chronic issues. So, we're using these quality measures essentially as a way to inform providers, just to give them insight into their own patient population, and also improve individual patient care, not just for patients that are in your face regularly, but looking at everybody within the population, and then looking for health trends. One of the primary purposes is to be able to find trends and disparities within practice populations and within regions, and then be able to address them. So hopefully data will be a big motivation for people, is be able to use that data so that they can improve upon it.
Well, what I like about this is that it really gets us to the point of all of this. There's lots of benefits that come from EHR and HIT adoption, but really to gather this data, that is really sort of the basic, what's the word I'm looking for? That's sort of the essential aspect of adopting this digital technology, is that we should be able to record all of this data. And so these programs encourage that effort. And then, as we build that data set, we can really start to make some progress in improving those outcomes as well.
Yeah, that's right. And it's hard because sometimes people just see it as checking a box. They say, oh, I need to be able to check that box, or I missed it, or maybe they think that they're doing something, and they don't necessarily know their EHR well enough yet to be able to tweak it and find the information, get and glean the good quality measurement information out of it. But that's the way we want to be going, is to be able to know that software well enough inside and out so that you can manipulate it in a way that it's used to not just your advantage but the patient's advantage, and everyone who's coming in. So it's a challenge, and we'll get into that.
Okay, well, we've got these different programs. How do each of the programs measure quality? What are some of the differences?
Well, they don't make this easy. I've mentioned before that they do this sort of choose your own adventure, because it can be quite taxing. So meeting the requirements for each program is somewhat complex. If people are participating in meaningful use, Stage 1 allows folks to report their clinical quality measures through attestation. That is going to be changing next year in 2014, folks will have an option to submit their clinical quality measures electronically online, and then also have the option that if they want to overlap them with their PQRS measures, they can do so as well. PQRS, you're allowed to 4 different methods of reporting. So there's claims-based, which can be either paper or electronic. You can sign up with a registry. If you're one of the lucky folks that has a PQRS qualified EHR, you can submit the PQRS data directly from the EHR. Or for groups that are reporting together and they have 25 eligible professionals or more, they can use the GUPRO web interface through the PQRS system. But that's only available to folks that have a larger group practice. So yeah, there's plenty of methods. It does depend, you know, with meaningful use, your folks are reporting as on the eligible professional level, and actually they're doing the same with PQRS unless EPs have, you know, 2 or more EPs can form a group. If they share the same tax ID number, then they can report as a group. And then, you know, of course, there's the financial reimbursements and implications that are involved. So, you know, although the window of opportunity for incentives is starting to close, at least in the PQRS realm, not necessarily in meaningful use. Meaningful use, we're aware of the incentive money that's out there, although it's becoming less and less. But for PQRS in particular, it used to be, I think, as high as a 2% incentive reimbursement on the allowable Medicare Part B charges, and that is now reduced down to 0.5 or 0.5%. And what people are really paying attention to this year is that their ability to successfully report in 2013 defines whether or not they'll get a penalty in 2015. So people are paying attention. And also, you know, this is, it's not necessarily easy. So it's resource intensive. You've got to get folks on board, making sure that everyone in the practice is working together as a team.
So all these different programs, different requirements, different standards, how can providers navigate this and figure out how to sort of make the programs work together?
Man, I found the coolest thing. So there is something called the Measure Alignment Tool, and it is provided by the National Quality Forum. And essentially what they've done, they've taken 16 different alliances and groups nationwide, everything from, let's see, the CMS Medicaid Adult Quality Report to the EHR Incentive Program, PQRS, the Shared Savings Program for ACOs, even the Value-Based Payment Modifier. I mean, there's, and then of course HEDIS, physician measures and health plan measures, which is all part of the patient-centered medical home information. And they've created this great spreadsheet that takes 179 of the approved measures and pretty much overlaps them, and it tells you, okay, which measures can you apply to multiple programs. So, you know, some measures you can use for multiple, and so in that sense you can kind of streamline efforts and make sure that you're maximizing, you know, the impact that you're, you know, of the efforts that you're making. So I found from this list of 179, there are 20 total measures that meet all of the criteria for both the CQM, the PQRS, and HEDIS, you know, and can be used for that are included also in the patient-centered medical home. So I will share that with you guys. But it is making sure that, like, whatever you can choose from there, they've got at least, they need to cover at least 3 of the 6 domains for CQMs. That's part of it. So this tool has done a really good job of just fostering coordination and alignment across these organizations and even regions. So it came out in February of 2012, and they since then have been working for ways they're kind of using this as an opportunity to continue aligning, so that as the years progress, that hopefully we can reduce the measurement burden and reduce duplication, so that we can essentially get everyone rowing the boat in the same direction. So I will definitely share that.
So is it, for people who are struggling with this, and sometimes, the number of options are almost more trouble than help, but if they focus on these 20, that's a great sort of core approach to take, where they can kill multiple birds with one stone.
Yeah, that's the idea. So if you were to look at the overlap and actually that's going to be the next slide, so maybe we can move forward and we'll talk about that. For PQRS and for CQMs, so you can do, for PQRS, you can look at the list of the CQM measures that are included in the EHR incentive program. So for 2013, before, it was a total of 44 different measures. But going forward in 2014, it's going to be a total of 64 measures. Now, if somebody really wanted to streamline their efforts and then also use these quality measures if they're in the process of becoming a PCMH, then they would be able to look at the alignment tool and say, okay, maybe instead of looking at that list of 64 or going off the basis of the 9 recommended core for adults or for pediatrics, maybe could look at this list of those 20 and see if that would apply. Does that make sense?
I think so. We've had a couple questions already, and I know you're going to get back into it, but when it comes to to skip back a little bit, the National Alignment Tool, where can folks find that?
Oh, we will definitely be providing a resource. Towards the end of this, there is a website where you can get the tool itself to see what is there, and then they also have written a pretty detailed paper and report that gives their lessons learned, and I think it's about 20 pages long or so. So they just talk about, giving it an idea of how they're going to be moving forward in the future, and continuing the alignment of these programs. So I think that's good news for everyone, and I certainly thought, once I found it, I thought like, oh, this is awesome, this is great. I think it'll be really helpful for folks in our community.
All right, so stay tuned for that resource. We'll be sure that you have that available. So how can providers use their quality data to support HEDIS then, which is kind of not a government program, maybe a little different than the others?
Actually, can we go back? I don't think I got to cover
I'm sorry.
that information. It's okay. So in speaking to alignment of the CQMs and the PQRS, there is, sorry to kind of disrupt.
No, please go ahead.
It's really important because this tool, there's the PQRS EHR Incentive Program Pilot, and that is what allows eligible professionals to align both the CQMs and the PQRS. So first of all, in order to do so, you need to make sure you're eligible for both programs. The eligibility requirements for both meaningful use and the PQRS are slightly different, but they're not too far off. And then if your practice does want to participate in both, you need to indicate your intent. So when you're attesting for meaningful use, there's a checkbox in the EHR Incentive Program registration and attestation module that you can click that lets them know that, okay, you're also going to be participating in the pilot program. So they just know to make sure to keep that information together. From there, you would determine the clinical quality measures that you would be using in your practice. And then I had mentioned before, like there's 2 different ways that you can submit this information for the PQRS. You can either use an EHR data submission vendor, or if your EHR is PQRS qualified, which is not the same as a certified EHR. So if it meets the PQRS qualified requirements, then you can submit that information directly from your EHR. Otherwise, you would need to contact a data submission vendor, which I can get the list for folks as well. And then if you're not using the data submission vendor, then you need to register on the IACS account, which is specific for the EHRs. And I'm going into a little bit of detail because it's important to make sure that each step is followed. So from there, you would document your patient information, generate the required reporting, make sure that you test the data submission if you're using the data submission vendor to help you submit that information, and then make sure that you remember the deadline is February 28th of 2014. And if you're submitting your CQM and PQRS data together via the data submission vendor, you need to make sure that you also are completing the EHR incentive program attestation by February 28th, 2014 too. So you'll have two separate submissions that you'll be responsible for. It won't all be combined together in the attestation program. And going forward for next year, this is something I found really interesting, is that the 2014 it's a special year in the sense that because of stage 2 being implemented, all of the reporting periods are only 90 days for everyone, and so that doesn't necessarily fit with PQRS. PQRS's reporting period is a calendar year, January to December, no matter what. So if you are trying to align your CQM and PQRS next year, even though your attestation reporting period may only be and it has to align with the quarter, maybe it's the first quarter, maybe it's the second quarter, you won't be able to submit all of the PQRS data until January 1, 2015, because that's when you'll have all of the reports for PQRS. So that's one caveat to, and I think it's an important one to mention, that if you're aligning PQRS and CQMs, you won't receive your attestation payment until the first quarter of 2015 for the 2015 for the 2014 reporting period. Let me know if that is clear. Does that make sense?
It does make sense. And of course, if it's unclear to any of our guests, please go ahead and ask questions. I want to remind our guests that you can ask questions at any time, and we'll answer those in the second half of our session. Obviously, this material is a little bit technical. There's no way to avoid that in discussing these quality measurement programs, but we're hopefully giving you some useful information. One other note, we've already had someone ask about the slide deck because they missed the first few minutes of the webinar. Not to fear, we will send out the slides after the event, so you'll be able to review both the slides and the video recording of this event. So now let's get into the HEDIS program, since it's a little bit different than CQMs and PQRS. Obviously, another important quality measurement program. How does all this come together and support HEDIS as well?
So I had to do my research on this one. HEDIS is 80 measures total, so 80 quality measures, and they report on all of them. So, and then they cover 5 different domains, and that was something that I found interesting. So all those measures are reported essentially when you submit your claims to insurance companies. So depending on the codes that are input on those claims, they're gathering that measure material. And I spoke with somebody over at the NCQF, the National Quality folks, and their representative, she was mentioning to me, like, the best way to support HEDIS is to keep all of, because there's inconsistent methods of collecting a lot of this data, and it can differ from provider to provider, and to make sure that it is accurate and complete. Whatever reports that you're generating in for CQMs and PQRS, make sure that you keep those on file, and if you want to share them with any of the representatives, from the health plans or anyone who's representing HEDIS, then that can be a very useful tool and certainly streamlined. She was mentioning to me that some practices may get audited, or they have somebody that comes into their practice to double check all of that paperwork to make sure that they've got the right numbers. And that can be very disruptive to workflow and patient flow. And the best thing you can do is just have that information on hand for them in the case that that happens to your practice. She also mentioned that just be aware that because of the way that they measure, because it's attached to a health plan, it is their denominator, and like what they're actually measuring is slightly different, because they're measuring based on a patient's continuous enrollment within a health insurance plan. So their denominator may include, it's not just the entire patient population that meets a certain subject or category. It's in addition to that, it's the patient population that has been enrolled in a particular health insurance for 2 years or more. That allows patients to to have gotten whatever test they need and to give them time to take action on that. So the numerator will very likely be the same, but be aware that there may be some differences in the denominator, and that's perfectly fine. It's just because they're looking for slightly different information. So her advice was just make sure that you keep those reports on hand and share them willingly when asked.
So let's, because this is a pretty abstract subject, I do think it's helpful to talk about specific examples. So give us kind of a case study of a doctor who's managed all these different programs.
Sure. Dr. Jennifer Brule, she practices over in Kansas, and she was explaining one of the things that she did. What she did was she took the breast cancer screening measure, which qualifies for CQM, for PQRS, HEDIS, and then she was on her way to start becoming a medical home. And what she did was she had to take her baseline, like, okay, she's getting ready. How is she performing? And from what she says, she never lets a patient leave a well woman appointment without getting a mammogram. Yet when she took her baseline report, for this particular quality outcome, she only had a 65%. Like 65% of her patients had been screened, and she could have sworn that every single patient that she saw was going and had been sent on. So it turns out, originally she thought that the data must be wrong. There's no way that it's capturing, real information. She didn't believe it. But it turns out that it was, because it was correct, because the women who came in for other reasons, not necessarily a well women's exam, or maybe women that didn't come in at all were not included in those numbers. So what she did was she ended up using her EHR to create a report of who fits in the category that should be screened, and then they sent out letters to all of those patients, and within 3 months or so, they were able to increase their results by 11%. So they got them up to 76% of patients screened. And what they had found was, that's pretty good. It's still kind of C level. It's not, passing with flying colors or anything. So she wasn't too happy yet with her results. So turns out that the letters are a great start. Being able to define who meets that category, but she mentioned it was sort of a high investment for a somewhat low return. And so her practice has meetings on a regular basis, and what they decided to do was have the nurses increase the order tracking. So the order tracking of these screenings to once or twice per week. Maybe patients were falling off the report, and they wanted to make sure that they were capturing everyone. And through that, they were able to increase their results between 82 and 86%. So that's around 6 months' time. They went from 65 to 86% of patients that had been screened, which is still pretty good, but not as great as she had wanted. And so what she ended up doing, which the nurses came up with an idea, you know what, why don't we send the order over to radiology, and we're going to have radiology call the patient to make an appointment. And it turned out that that was the trick. And it didn't have anything to do with the EHR or whatever, but they had defined who needed it, and then they took a step, they called radiology, and then when the radiology lab would call the patient, they were very quick to act. You know, a woman's like, oh yeah, it's time for me to have a screening. Okay, do I want to make an appointment this week or next? You know, you give somebody that option of like, all right, do you want to do it now or today or tomorrow type thing, and people would make the appointment. So over a period of about 10 months or so, she was able to get her results up to 99%. And what she had said, from theirs was that 1% that she didn't, that decided not to get, that she couldn't get because they never were able to get, obviously, to 100. She said that she was kind of hanging out in the 97 to 99% percentile for a while. She knew every single one of those patients and why they wouldn't come in. And it turns out that 1% were those patients in particular either didn't believe in radiation, they were never ever going to let, willfully let their body be subject to any radiation, or maybe they were waiting for a free mammogram. They were waiting for some sort of grant program and they didn't have the money to pay for it, but she knew them. And she expressed like how this is really something that allowed her to know her patients better and even work with the team to drive to getting better results. So her lesson learned there was, make sure that you're actually trusting the data and, listening to it. And even though you think, this was a case where she thought that she was doing a fantastic job, but by, generating these reports was able to find ways to improve. And, typically I think if given the opportunity, providers and physicians want to provide the best care. So to be able to get some insight into doing that, it can be a very good thing. Although it can be very complex, it can also be really amazing with great results. So,
well, it certainly shows how these efforts can truly improve outcomes. I mean, you can really meet your medical goals here by using this data to support your efforts, and that simply, even someone who's on top of it, clearly this is a very conscientious doctor, and she was making every effort to get everyone screened. Just, sort of intuitively going through it is not enough, and using the data really can make a big difference in the outcome.
Yeah, she gave another example, which was the colorectal screening, and she, that one she had much lower baseline. I think she had 43%, and over time she never was able to get it up as high as her breast cancer screening, but she was able to get it, I think, up to 85%, and based on that data, there were 3 patients in particular that she was able to point to and say, if we hadn't been paying attention, if we hadn't been going through this process of trying to do all this preventative care and capture, this quality measurement of these patients, there were 3 patients she knew by name that she was like, we wouldn't have found, we wouldn't have been able to find or treat them for this particular cancer. And she's pointing out pictures that like now they're happily living and vacationing and spending time with grandchildren, and it could have had a completely different outcome. So it's important. It really does make a difference, and I know it seems just like reports and numbers and data, but it does touch people and have a lasting impact. So just want to drive that home.
So you've been giving lots of good advice on how to coordinate these reporting efforts, but give us some more strategies on how practices can go about managing this terrain.
Well, one, know that this is not an easy task. It's not something that is just there's no staple easy button that you can press and say like, all right, we're done. And it's one of those, the beauty's in the journey, not the destination type situation. And it's really important to make sure that everyone is coordinated and is on the same page, and one way to do that is to make sure that there's a lot of staff meetings either once a week or every other week, and making sure that like you're pointing out specifically to, all right, what is your intention. What are we going to be focused on this particular, for the next week or for the next month? Let's work on one thing and try to get our outcomes a little bit better. It's also important to make sure that if you have multiple providers within a specialty, that they are working on the same quality measures, because that can be a little bit tricky when it comes to reporting. If different providers have decided to have different to report on different measures, it's doable. But if you want to streamline your efforts, it'd be better to have everybody on this reporting on the same ones. And then when you get into the patient-centered medical home and ACO path, it's even more important to have coordination. Like, it's really important. Like, so I think that the biggest things that practices and providers can do is to show enthusiasm, be leader, don't be afraid to communicate, don't be afraid to fail. And if you don't like your numbers, or if you don't like the particular outcomes that you're getting, then that should be a drive to do better. And knowing that is going to have hopefully better outcomes for your patients, and maybe give an opportunity to build on those relationships and provide better care for these folks. I think it's really important.
So there's big changes coming to meaningful use with stage 2 and PQRS. You've described some of the changes coming there. So 2014 is a big year for lots of different reasons. How is this all going to change, and how can people get ready?
Well, it's sort of moving targets. There's so depending on what stage you're in for 2014, no matter what stage you're in, you're going to be reporting meaningful use for the 90-day period next year. They do change the measures, so the measures themselves will be changing. In 2014, clinical quality measures adds 20 approved. I don't believe any have been taken away. They've just added 20 new ones. And PQRS, those, if you're aligning, they align well with the CQMs. But if you're just working on the PQRS measures and not aligning, those measures change on an annual basis as well. So, for example, this year, I believe 10 measures were added to the PQRS approved list and 15 were taken away. One measures group was added and one was taken away. So make sure that if you've reported PQRS in the past, double check and make sure that whatever that measure is, that it is still on the on the list. Because it would be a shame that if you're tracking something and then you just assume that it's still there. If you're one of those folks that was measuring one of those 15 measures that got dropped off the list this year, that could be a real shame. Pay attention also to the reporting periods. So for, like I had mentioned earlier, the CQMs are a 3-month deal next year, and then, but going forward in 2015, it's essentially going to be all year round. So, and I think that is kind of what is leading into this whole, like right now we're in a place where you get the incentive for reporting. It's essentially a pay-for-reporting model, and as the reporting periods grow to be a year long, either the whole fiscal year for hospitals or the whole calendar year for ambulatory or outpatient providers, seems to be that we are moving in the direction of a pay-for-performance model. So the better you can start, capturing and knowing where you are now is only going to help you meet that and get, reap the benefits as we move towards that model going forward.
I think that's a great point. So people are obviously, there's, been plenty of growing pains as people try to ramp up these programs and really move toward, a new way of doing business, recording all of this data as part of their clinical practice. But this stuff isn't going to go away either. The incentives are here now, and there will be penalties in the future. But all of that aside, it does appear that medicine is moving in the direction of pay for performance, and this collection of data is just going to get more intense over time. I think is a reasonable expectation for folks. So it makes a lot of sense to get on top of these efforts now, so that they're in the practice of doing it.
I agree.
So you've got, here's the URL for folks who are looking to get a hold of that NQF alignment tool. You can see it as the top URL there. And again, we will send these slides out to everybody, so you'll be able to look at them now, but you can jot this down. You'll be able to look at them later, but you can jot this down now if you want and visit the alignment tool. Joy, tell us a little bit about these resources if you could.
Yeah, sure. So the NQF alignment tool is a hefty Excel document is what it ends up being. So you can see the layout of what exact measures meet which programs, both private and public. I highly recommend checking it out and seeing how it works. You can go to the qualityforum.org website to get more information about them as well. Just as I was mentioning, they have lessons learned, and just they give you an idea of how they're going to be aligning these measures in the future. So I find it comforting to know that folks are working together to try to make it easier and reduce the burden. So, I know that it's really complex and complicated right now, but it will be getting easier. That's the takeaway from that. And the CQM, PQRS, if you want to align both of those, this document right here will help you give you step-by-step information on how to participate. So if you want to find that list of an EHR data submission vendor, it would be included there. And if that's not enough, if you want to speak to somebody in person, there's the CMS, although they are shut down, so I'm not sure that anybody would be answering that call today. But
presumably the government will open its doors again at some point, and then you'll be able to.
Yeah, exactly. So I'm sure that they'll have a backlog of emails, but if you want to email them, you can do so at that QNet support email address. And then for HEDIS information, there's the NCQA. They're the ones that sponsor that that program. And then this piece, the patient-centered medical home. It's also on the NCQA website, but I think that they give a really good visual idea of what it takes to get involved and to get started down the path of becoming a PCMH, to really understand all of the requirements and criteria and things that you should be involved in. They've got everything from videos to step-by-step instructions to surveys and really nice resources. So I thought that would be good to share with our network.
Well, it's great you always bring all of these resources with you to these learning lunches, and I know that people really appreciate that you're able to sort of find these and collect them for everybody, because there are a lot of resources out there. It's not always easy to find where they're located.
It took me forever to find that alignment tool, I'll tell you that. You would think that I would be able to. I feel like I'm pretty good at finding stuff online, but that alignment tool took me a while. And once I did, I was screaming, Eureka!
Well, I'm sure that a lot of practices out there would feel the same way, and it's a shame that it's not easy to find, because it's obviously a very useful tool for people. So this is here's a case where people are really going to need the slides when we send those out, probably. But this is a great. I love this. This is another great resource. If somebody just needs to know, what should I track? What are the basics? Tell us about the slides that we're going to review.
Right. Here. So I actually went through the alignment tool, and I went and highlighted all the ones that are, that measure that can be used for the multiple programs, CQM, PQRS, HEDIS, and things for PCMH, and I found 20. So this is, I think, the first 10. If you want to take a look, hopefully, if any of these can be used in your practice, like, congratulations, you made the final cut. Like, that's awesome. You can streamline using these, and then I think that there's one more slide that has another.
Yes, here's the second slide for folks.
Mm-hmm. So these would be the winner chicken dinner category. Like.
And a lot of this information really is very basic clinical information, and it makes sense that all of this needs to be recorded. I mean, well, not for every practice, but you can see that this is all very basic information.
Sure, and if it's stuff that they should be, that, you know, especially with folks that are tracking anything like with diabetes, you should be tracking that stuff anyway. So hopefully what you'll find is that this is stuff that you either have already been doing, and maybe it's just a matter of learning the EHR a little bit better, so that, you know, you can get the information you need from it, and so that it can generate the, you know, the reports. So that you can use that to improve. And essentially that's what we're going after, is improve quality, improve outcomes. And so in order to do that, you know, one, you got to know where you are. So thankfully, EHRs help us to do that.
All right, well, we've saved some time for questions and answers, and we've already got quite a few questions. If you haven't asked your question yet, please go ahead and type that into the chat area, and we'll share it with our presenter. But let's go ahead and look at the questions we've got already. And I'd like to remind folks that we will be sending out written answers to these, and if any of these questions are especially technical, we may defer to the written answer to be sure that we give an accurate answer. But let's see what we've got here. So someone's asked about PQRS reporting, and they want to confirm that it's a full calendar year that needs to be reported?
That is correct. So there's only one instance in which somebody can use a 6-month, and that is if they are registry based. So if you're, and I believe it's if you're a group of 2 or more that is going to be submitting your quality measures via the registry, then that's the only way that you would, you know, I think that essentially what has happened is that the registries are more accurate. Like you get a higher rate of successful submission through a registry than through claims, and so I think that was an incentive to get people to sign up for either the group-based registry. But all other submission requirements are calendar year. So if it's claims-based, either paper claims or electronic-based, it's calendar year. If it's EHR data submission, it's calendar year. And if it's group practices using the web interface, that is also calendar year.
All right, here's a question about GPRO. It says, must an eligible professional report in the GPRO incentive pilot program in 2013 to report as a GPRO in 2014?
Wow, that's a really good question. I don't know if there is the requirement that you actually must do that this year, but I will look into that and find out. I would hate to say the wrong answer.
All right, well, we'll follow up with that one and give you a written response to that question. All right, here's another question. Can you report all of the objective measures for meaningful use, and then in January report CQM and PQRS?
Yes. Yeah, you can definitely. I think that's what they kind of intend you to do. So if you're going to be next year submitting your meaningful use, the attestation part, you can complete and attest once your reporting period is over. And I need to double check when you can actually attest, because I believe that like, for example, I tried attesting for a doctor who gave me results from this year, and I'm not able to submit it until January 1st of next year, because you have to report on last year's information. So let me double check on that too, but my inclination is to say yes, you will be reporting them separately. You'll be reporting the 3 months of the 90 days of the attestation for meaningful use, and then you would report the CQM and PQRS information at a much later date, the following January 1, between January 1 and February 28th of the next year.
All right, here's another question for you. To satisfy my 2014 meaningful use CQM requirement, if I submit 9 CQMs covering 3 domains based on a January 1, 2014 to the end of the year reporting period, I will have fulfilled both the 2014 CQM and the PQRS requirements. So obviously the CQMs, you don't need the whole year, but if you're doing, you cover both then, I think is the idea.
Yeah, that's right. That's exactly right. Now, just make sure that when you submit, so you would not be reporting you would be reporting the CQM and PQRS data separately from the attestation. So the actual, performing of the work that is required in that time frame, yes, you would be fulfilling the requirements, but you just need to make sure that you are submitting and attesting in the 2 separate areas. One would be specific to the EHR incentive program, the meaningful use side, and then the other would be the one that would include the PQRS data. So you can either do that through the Medicare, the PQRS Medicare EHR incentive program pilots, or you can use the qualified, if you have a qualified PQRS EHR, or the EHR data submission.
So we have a question about reporting periods and CQMs, and I'll let you address this question. The issue is someone thought that CQM was 3 months, or is it 12 months? And this has to do with the stages, doesn't it?
Yes. So meaningful use stage 1, at least first year, you've got your 90 days. Total of CQMs. And then what's supposed to happen is in your year 2, so we're talking meaningful use stage 1, year 2, it's supposed to be a full calendar year. However, because CMS is allowing all the EHR vendors time and providers to catch up with all the stage 2 requirements, the year 2014 is like this special year. So it's the only time that if you're in year 2, you would only need to report 90 days of quality, the CQM stuff. So your year 3, 4 and 5 would be full calendar years. But, the caveat is that if you're going to do CQMs and PQRS in the year 2014, you're right, you only need 90 days of CQM data, but PQRS requires the full calendar year. So you kind of have to just wait or continue doing them.
And then in 2015, people will be back to a full year of CQM reporting, most people.
That's right.
Here's a question that actually raises an issue that I thought about as you were speaking. The CQM and PQRS have been tied to incentives. Will they ultimately be tied to payment adjustments? Certainly we know that meaningful use will, but I was thinking about PQRS, how the incentives are falling, and what comes next. When will that occur, and what are the scale of the penalties?
They go up to 2%, and they stay at 2%. So
that's for PQRS.
That's for PQRS. Let me have a really good timeline here. So the incentive for PQRS in 2013 is 0.5%, and also next year 0.5%. Now going forward, 2015, 2016, 2017, etc., there are no incentives. So this is the last of them. So if you think PQRS was launched in 2006, reporting started in 2007, and I believe that the incentive was as high as a 2% incentive back then, and it's been slowly dropping off. And so now you've got, in 2015 is the 1.5% penalty, and that penalty is based on the reporting of 2013. So whatever you do for this year is what's going to define what your penalty is in 2015. Same situation for 2014 and 2016. So whatever happens, whatever reporting you do in 2014, if you end up not reporting or not successfully, if if you have unsatisfactory reporting or you decide not to participate in this year or next year, then you would get a 1.5% penalty in 2015 and a 2% penalty in 2016. It caps out at the 2%, so you know, that's as high as the penalty goes. But if you were to start combining the penalties of PQRS with the penalties of CQM, it could add up. Yeah.
Well, especially with these shrinking margins. So, you know, the other thing is on the meaningful use front, those reimbursement adjustments, those began in 2015. Is that correct? When did those begin? And those rise to 5%. Over time.
Yeah, those go up 1% per year. So is that right? It's what? Yeah, it goes.
I believe 1%. So. Yes.
Yeah, so it's a 1% penalty in 2015, 2 in 2016, 3 in 2017, etc. And so that to 2019 it goes in 5%, and then it caps out there. So if you just decided to do absolutely nothing and you still have Medicare and Medicaid patients and don't participate in any of this stuff, then by 2019, you could see yourself having a 7%, reduction in reimbursement.
So there's certainly financial incentives and disincentives involved here, but of course, really it all comes back to patient care and the outcomes that you've been discussing throughout this session. Well, I'm afraid we're out of time for today. We didn't get to all of our questions, but we will send out written answers to those. Again, look for the email that we'll deliver a little later in the week with links to the written answers to your questions. Thank you, Joy, for joining us for today's Learning Lunch. It's a difficult subject, but I think you shed a lot of light on it for folks. Read Joy's column. It's called Ask Joy. You can read that column at Format Approved. To keep up with meaningful use and HIT topics, visit our homepage at formatapproved.com, click on the Content tab, and then select Joy from among our regular columnists. Remember that Format Approved provides an abundance of free educational content on meaningful use, HIPAA, EHR, and more. So take advantage of that free resource. I'd also like to thank all of our attendees today. Remember that all registered attendees will receive an email with links to both the slides and the video version of this session. For comprehensive training in meaningful use, register for Format Approved's Certified Meaningful Use Professional course. The course covers the requirements for both Stage 1 and Stage 2 of meaningful use for both eligible professionals and eligible hospitals, along with clinical quality measures. So if you're looking for information on CQMs, there's great material in that course. There's also your HIPAA requirements and lots of additional information to help you attest for meaningful use. Visit formatapproved.com to learn more about our upcoming Learning Lunches. The Learning Lunch button will take you to our entire slate of webinars. Our next Learning Lunch will air on October 15th, and we'll cover the subject of ICD-10, Physician Practices, Where Should I Be in My Implementation Process? Next week, Format Approved will not be doing a Learning Lunch. Instead, we will be broadcasting live from the MGMA conference with healthcarenowradio.com. If you'll be attending MGMA in beautiful San Diego, California, visit booth 329 to see the Format Approved team in person. You will see that we're glamorous almost beyond description. That's not a guarantee. You can't hold me to that. Best of all, you might get a chance to snag Joy Rios for a one-on-one conversation. So if you're going to be there, please stop by booth 329 and see us. Keep an eye on your email box and our homepage for other upcoming topics. And thank you again for joining us today.